Good morning, everybody. My name is Dr. Vinay Deshmane. I'm a breast cancer specialist at the Asian Cancer Institute. Good morning, everybody. My name is Dr. Vinay Deshmane. I'm a breast cancer specialist here at the Asian Cancer Institute. Good morning, everybody. My name is Dr. Vinay Deshmane. I'm a breast cancer specialist. Let's start with the basic of breast cancer. Good morning, everybody. What causes cancer is something that we ask. We really don't know what causes cancer, but we know that certain cancers are associated with cancer. What causes cancer? Basically, it's not a very political or genetic factor. We know that some infections. What causes cancer? What is important to understand about breast cancer? One of the common things that people ask me is breast cancer is wrong. Yes, it is common in the community. Breast cancer is the commonest cancer in the country. It has overcoming cervical cancer, which is mostly the commonest. Is it advancing very rapidly? No, it's not really increasing very rapidly as overcoming cervical cancer. If you really look at rates of increase of breast cancer, the rates haven't changed, and rates are calculated for lack of population. So this lack of the rates have changed very marginally. The sheer volume of our population which has increased in numbers, lack of population. The next question people ask is it very common in young people? No, it's not common in young people. The commonest age really developed or seconded by breast cancer people are in 50 and 60. Then it's between 40 and 50. Then 60 and 70. So 40 to 70 is the commonest age, and 50 to 60 is the commonest. Are there any particular reasons why people develop breast cancer? Yes. Late first age of marriage. Breasts which have been denied their function, that means lack of breast cancer. Extra hormonal drugs being taken. These are all usually associated with the development of breast cancer. Very often, people ask when they have had breast cancer, why has breast cancer happened? And there is no clear answer that this is the reason why breast cancer has happened last. And this is very, very important to understand because very often there are guilt feelings associated with the breast cancer patient. When I've done something wrong, that's the reason I have developed breast cancer. The other question they worry is, what about my family? Is breast cancer hereditary? About 15 to 20% of breast cancers will run in families. That means there will be a trust of family members. But only 7 to 10%, I'm repeating this, only 7 to 10% are actually identified with the generation of family members. That means the vast number of cancers is actually have nothing to do with your genetic abnormality, genetic inherited through your family. Is it associated with some genetic abnormality? Yes. Every cancer in your body is basically associated with some genetic abnormality. What does that mean? Is it associated? We are all born with a set of genes. One comes from our father, one comes from our mother. These genes basically allow this basically the information which is being passed on, which tells the cell how to live, how to divide, when to die. With our daily life, all these genes do get damaged on a regular basis. But we also have repair mechanisms within these genes which control or repair this damage and prevent these abnormalities from going on continuously down the line. Somewhere along the line, when these abnormalities cannot be controlled, the cell loses its ability for self-regulation and then starts multiplying and becoming abnormal. Somewhere along this process can take as many years, 7, 10, 15, 20. We are not really sure how long this takes. So everything that happens in your body, including a cut which is healing, actually happens because of some genetic information. That means the genes are telling the cells when to rise and when to stop. And this dysregulatory function results in cancer. Only 7 to 10%, as I mentioned earlier, because of the genetic aspect. There are two major genes which have been identified: the BRCA1, or the BRCA, or the breast cancer 1 and the breast cancer 2. These can tell you if you have a mutation or an abnormality in the function of the gene, then you can there's a chance of developing a breast cancer to be identified. Unless it's really as much as what we really know on hereditary breast cancer, there's a chance. The ones who actually have a genetic abnormality will have an abnormality or for a possibility of developing a breast or an ovarian cancer. Will everybody who has a mutation always develop a breast and ovarian cancer? No, that's not possible. That may be 60 to 75% in develop. But that may not necessarily be in the next few years, but maybe over the lifetime of that individual. And that's also extremely important to understand. It's not that somebody has a gene abnormality and will develop. It just means that that risk of lifetime person developing or a chance of developing cancer in that individual that somebody has a gene abnormality and will develop. Just any questions that that risk of lifetime person developing or a chance of developing cancer in that individual that somebody has. So basically, how does it spread? Cancer spreads basically by cells multiplying and growing. Somewhere along the line, they secrete enzymes which cause a breakdown in the tissue around it. Then the cells can access your bloodstream or the lymph which has small thin vessels and fluid, and then they can spread all over the body. Where is it spread? Common sites of spread are local, that means in the area around it, or it can spread to your bone, it can spread to your lungs, it can spread to your blood. This is called metastasia around. One of the other questions very often that people ask is, what is the stage of my cancer? There are two different kinds of metastasia. People very often are confused with grade or tumor. Stage. Grade refers to how bad the DNA is in a cancer cell, that is how aggressive is a cancer cell. And that is generally classified as grade 1, 2, and 3. While stage refers to where all is the cancer in your body or in the organ where the tumor is to be done. For example, is it only in the breast? Is it in the breast or the liver nodes? Or has it spread to any liver, other soft organs in the body like the liver, lung, bone, brain? So that is the stage. Survival of a person generally depends on the stage as well as the aggressiveness of the cancer. And the treatments are also related to how aggressive the tumor is and how much the tumor is spread in the aggressiveness of the cancer. How is it that this sort of a cancer diagnosed? Because the cancer is usually diagnosed when a person comes in. The common complaints are basically a lump in the breast, a change in the shape or the skin of the breast, a new lump which comes up in the armpit, or the nipple or the area has changed in shape, or there's some discharge coming out from the These are all signs which may indicate that someone requires to investigate and find out whether they have cancer. Do all these signs indicate that they particularly that anyone who has found these signs has cancer? No, it doesn't necessarily mean. But the vast majority of people who generally have non-cancerous tumors. The commonest non-cancerous tumor we actually see is something called the microadenoma. And if we examine people, we do not detect as many as the number we detect by doing ultrasound examination. So if somebody undergoes an ultrasound examination, it is very often that you may see tiny lumps in the breast, which may never ever manifest in their lifetime and may not have any danger to an individual. So every lump in the breast is not cancerous. We diagnose a lump in the breast when it's cancerous or not. We do further investigations. The common investigations are besides breast examination, mammogram, which is basically an X-ray of the breast, and new advances called nomogram medicine. It's a far better digital mammogram of the breast, which actually slices the breast like a lobe and you check each slice separately. You do an ultrasound, and ultrasound can pick up 10% of lumps which are missed on the mammogram. And in certain individuals who have high risk of development of breast and ovarian cancer, very often we can do 10% of breast cancer. The breast MRI needs a special foil, usually done in centers which really are very often breast MRI since their investigation can be the best MRI needs a special. Once a lump is picked up on a mammogram or clinical examination or ultrasound, the radiologist then decides or advises do these lumps require biopsy. We may suspect a lump to be malignant on examination or an investigation like this with imaging technology like mammogram, ultrasound, or MRI. But it's important to understand that it can be only diagnosed by a pathologist. That means we require to provide either cells or preferably tissue, which is really done by what we call a core needle biopsy, a slightly larger needle in the organism, which actually goes into the tumor and takes a very fine layer of tissue, which is then sent to the pathologist. Olden days, all these lumps used to be biopsy. Surgery, you make a cut of the breast, take out the lump and give it to the pathologist. Today, under the ultrasound, they can put in the needle, which is into the tumor and search for a spot liver, which is sent out to the pathologist within 48 hours. You can generally get an answer as a tumor, cancerous or not cancerous. Olden days, we just said what we call the fine needle aspiration cycle. It is still practiced, and it's very useful, very quick, can be done in the outpatient. But there we get just a few cells which are spread out on a slide. While in the core needle, we actually get tissue, which is more like an open surgical biopsy compared to the cytoplasm. The other important difference that one requires to understand is there are two types of cancers. There is a cancer which invades the body, which is generally referred to as cancer in the abdomen. That is an invasive cancer. An invasive cancer means the cells that come out from the guts of the breast and can actually spread anywhere in the body. A non-invasive phase which is enclosed within the ductal tissues of the breast and are localized and actually these do not spread in the body. And of course, I will not at all as compared to invasive. So the reason I mentioned these is the cytology results and the core needle biopsy. In a cytology, you get cells. So you cannot say it's invading or non-invasive. In the core needle, I actually get tissues and differentiate the cytology into these two subtypes. So they can actually see things which are invading into tissue, and you know you're dealing with an invasive tissue. This distinction is quite important because it reflects on the type of surgery one has. If you have an invasive tumor, you do require to take out some of the lymph nodes in the arm to find out how the cancer moves from the breast to the lymph nodes. If the tumor is non-invasive, these lymph nodes will not require to take out some of the lymph nodes. So it's very important to differentiate these two. And of course, this brings to a very important to the oncologist who not only diagnose the tumor, but also to give a subtype of the tumor. Basically, we don't just look at the tumor and say, well, it's a cancer versus non-cancer. We also look at certain things called biomarkers, subtype. We look at certain receptors which can be responsible for treatment to the tumor, specifically estrogen receptors, progesterone receptors, something called a growth receptor. We look at obviously these cells are multiplying for the Ki-67 receptor. And then we may look at certain other special progesterone receptors. So pathology is extremely important. Once we have diagnosed the tumor, which is based on imaging and confirmed on the law, we do something called staging. Once it's staging the cancer, we do is we scan the body, or we do certain. We basically do three types of tests. The first I've already told is to diagnose the stage of cancer. Once you diagnose the presence of cancer, the next set of tests we find out how much is the cancer in the body, only in the breast. Has it gone out from the breast to the local lymph nodes which are draining the breast, or has it gone to other organs within the body, like the liver and lung? Now, when the tumor is very small and the chances of it spreading are very low, we don't tend to do major scans. But one of the common scans which is now done when we suspect the tumor may have gone beyond the normal, or we suspect that they have gone somewhere else, or the chances of it spreading in the body are high. There's something called a PET CT scan. Some centers will only do a CT scan of the thorax, and the abdomen, while some centers will do a CT scan along with the PET scan. Olden days, we were just doing a chest X-ray, a liver function test, and in some cases, the ultrasound, the abdominal test. So although long-term monitoring is still done by this, we don't repeat the scans unless there is a necessity of repeating scans again and again. We tend to just do these basic investigations and the special scans in certain unless there is necessity of questions. So once we've diagnosed the cancer, we stage the disease. In staging, as I said, we do basic blood tests. We will do, so having a test X-ray, diagnosis of the abdominal, and selected patients, we do the PCT scan. Once we run tests, what is the status? We tell us the stage of the disease. That means you diagnose a tumor and you know its extent in the body. These two things we can understand. Once we have stage of the tumor, we decide is it localized, which is relatively early, or it is advanced. It's very important to make this distinction because there are three major treatments for most solid tumors. When you have solid tumors, when you have a solid organ, it's very passive compared to what we're talking about when you have cancer in the blood. So we talk about blood cancer, leukemia, and solid tumors. But for solid tumors, there are three major treatments. You have surgery, you have radiation, and you have drugs. The advantage of drugs is it goes all over the body as well as into the breast. So you can treat cancer in all these different ways. While surgery and radiation have a localized drugs, so they control the disease at the site of origin of the breast. When you have an early tumor or early stage radiation, the chances of it having spread are less. That's why there is much more emphasis on the local treatment. That is a combination of surgery and early stage. When the disease is actually gone up by the chances of spread are higher, you do require some local treatment. So if you have early breast cancer, where the disease is basically relies on surgery, with or without you require some local treatment. If it's an advanced tumor, you can start on the drug treatment first. Try and control the disease in the rest of the body before addressing the disease at the primary site. Surgery can be divided into two types. Surgery, you have the old type of surgery was the mastectomy, which is commonly being done for over 30-40 years. And the new type of surgery will be trying to conserve the breast. Why are these two types now? Or these some types of surgery now? Because most will do exactly the same lifespan. It's not that if you have a mastectomy, you are going to live much longer than people who have actually had a breast conservation. In breast conserving surgery, as well as the mastectomy, the tumor is completely removed. When you conserve the breast, you just take a margin of tissue around the breast and we confirm that these margins are completely closed. In a mastectomy, in addition to the tumor, the whole breast is removed. So if the tumor is very small, it doesn't make sense to remove the whole breast because it will not add to the lifespan of the person like immunotherapy. It doesn't mean that if you do a mastectomy, you will not get chemotherapy or the drug treatment. But that depends on the final pathology of what you do. It doesn't mean that. So you have these two choices, mastectomy and breast conserving surgery. Breast conserving surgery will remove the margin of compromise and we address some of the lymph nodes in the arm. When you undergo a mastectomy, do the mastectomy as well as remove some lymph nodes in the arm. So the part of the armpit part of surgery where we remove some of the lymph nodes is not across the whole mastectomy. It's not the extent of surgery within the breast which is done. As I told you before, it does not change the span of life that there is no lack of living crisis, which is why the extent of surgeries are accepted all over the world. It's not necessary for over 30 years now, and in time alone shown to you exactly the same result. You should undergo breast conservation. First of all, it depends on the patient. If the patient isn't convinced that this is right treatment or she should be very convinced that she does want the best patient. There always be the patient's wishes of the patient is important. A breast conservation should not be done in a person who is convinced that So the patient's wish whether to preserve the breast or remove the breast is the most important decision maker for us. Second question comes if a person says I would like to preserve the breast, we try and preserve the breast very large. In this case, we can get this contraction, then we move to a smaller size, and then do a smaller operation. As compared to a small tumor, then we may just kind of go ahead straightforward with an upfront surgery contraction. It's not true that a person with large tumor will be required to do that. There are newer techniques for plastic surgery where it's straightforward with larger chances of breast and still get cosmetics as good an appearance as that of a person who's had a smaller tumor. Sometimes you give drugs which bring the tumor and do a smaller operation and still preserve the breast. A breast preserving operation is done as well. The difference between that and a mastectomy is the relation of the role of radiation therapy. A person who has had a breast preserving operation has to have radiation. Radiation therapy is not dangerous. It's very similar to what is happening to our psychological of radiation. When you walk out in the sun, you get some radiation. So you can radiate all the time. But this is the focus beam of radiation, which is going only to the breast area. Everyone who's had a breast conservation care when you walk out in the sun, the rest of the breast will be radiated all the time. But this gives the same result in the second. If you have a mastectomy, the chances of getting radiation can be as low as just 5 to 10% because you have an aggressive treatment. That means if you remove the whole breast, you may be able to avoid radiation. If you have a the chances you do require radiation by just 5 to 10%. Then the next question is, how long is the radiation to be given breast? Generally, there are 2 ways of giving radiation. There are very short courses of radiation which can be given in the office over 4 or 5 days. Some are only in the office on the table. But at least have to be less clinically. I mean, you don't have long-term results available on the technique. So we surely use these results. So by and large, all over the world, except in certain centers, radiation is given for about 30 seconds. Radiation doesn't take much time. It takes only 3 to 5 minutes to deliver the dose. But it's just the time radiation is going to a hospital. The reason for your frequent breakdowns of the radiation doesn't take much. These are all the technical problems or logistics problems that are associated. It's just that radiation really is not a problem, but it doesn't have many side effects. It may make your skin slightly dark. Coming to drug treatment, most patients are extremely worried about chemo side effects. Chemotherapy is required because use has been increasingly used from the most patients in a way which reaches maximum utilization around 2005 but we have slowly realized that it may not always be effective in everybody, and hence the use of chemotherapy is slowly being more and more customized to the needs of an individual patient. Chemotherapy can be considered in everybody like a blind machinery of cells. It just kills all the cells. It's supposed to kill all the cancer cells, but also kills certain normal cells along with it. We now realize that certain type of tumors, certain subtypes of tumors, which was biomarkers I spoke to you about earlier, those are estrogen receptor positive, strongly positive, where we can use hormone and certain type of those sort of tumors may not always require biomarkers. To just come back to what we call systemic treatment. Drug treatment can be divided into 3 subtypes. One is chemotherapy, the second is hormone therapy, and the third is what we call targeted therapy. So what are these? I said chemotherapy works against everything. The hormone therapy is directed against an estrogen receptor. That's a hormone receptor targeted on certain cancer cells. So these tumors will respond to the hormone therapy's anti-hormonal agents. So when you use anti-hormonal drugs, they block the hormone receptor on the cells, and that's how these work. So they are more like snipers. You have a cell, you have that receptor can be blocked. So the cheapest drug really which was discovered years ago for amoxicillin was one of the first targeted agents. It's not really referred to as a targeted agent today because they call it the hormone treatment or anti-hormone drug. The targeted treatment that we talk to about is the anti-hormone agent. Herceptin is a famous drug or it contains a chemical called trastuzumab. If you have a HER2 positive targeted on the cancer cell, then you use the anti-hormone treatment. So these are three treatments: the chemotherapy, the hormone therapy, and the targeted treatment. The hormone therapy and the targeted treatment generally are associated with much less side effects as compared to chemotherapy. People are very worried about chemotherapy, mainly because of the loss of hair, nausea, vomiting, which is associated with the chemo side effects. But the commonest problem with the chemotherapy really is, which worries most of our patients, is the loss of hair. There are newer techniques called solar caps, where they put the scalp, but these have not always been proven to be very, very effective in preventing loss of hair. There are newer techniques. The other factors like the drop in blood counts, which also happen with chemotherapy, can very often be easy control with newer drug which are given. They stimulate your bone marrow to produce more cells, and this lets you get over the chance of infection. Very often because of a drop in the count of the white blood cells following chemotherapy. So these side effects are now far better controlled than they were, let's say, 10 to 15 years ago. But in the community, there still is a lot of worry and also some sort of misinformation about the side effects of chemotherapy. And this requires to be very clearly understood. The side effects are far better controlled than they were, let's say, 15 years ago. But in the community, there still is a lot of... I believe there was some problem with the audio clarity, hence I'll just recap a little bit of what I had said. There are two types of breast cancers. One is early and the other one is advanced. And there are three treatments: surgery, radiation, and drugs. Surgery and radiation are a combination which is used to control the disease in the local area, that is in the area of the breast, while we use the drugs to control disease in the rest of the body. And it's important to understand why, because cancer starts in a place and tends to spread all over the body. So we use these combination of treatments to control the disease. Surgery, there are two types. You can preserve the breast or remove the breast. Both give the same lifespan. It's not that if you remove the breast, you live longer or is a better treatment as compared to breast conservation. In breast conserving treatment, we take out the lump and we take out some lymph nodes under the armpit. In the mastectomy, we remove the whole breast and we take out some lymph nodes under the armpit. So the under the armpit lymph node surgery is common to both. It's just the magnitude of the surgery in the breast which is different. The difference in treatment between a mastectomy and breast conservation is only related to radiation therapy. If you conserve the breast, you have to take radiation therapy to the breast. While if you remove the whole breast, you may be able to avoid radiation therapy. And radiation therapy is required only in about 5 or 10% of patients who will have really aggressive disease. So that's the difference. A common conception is that if I have a mastectomy or removal of the breast, I can avoid chemotherapy. No, drug treatment is common. It depends upon the age of the person, it depends upon the general condition of the person, and most importantly, depends upon how much is the tumor in the body. That means what's the volume of the disease in the body and how much has it spread. So surgery and radiation, as I said, is used to control the disease in the local area, and drugs are used to control the disease in the rest of the body. Drugs are of three types. There's chemotherapy, there is hormone therapy, and there are targeted therapies. Chemotherapy is basically chemicals or like antibiotics which are given specifically against cancer cells. They're generally given in drips and are given in courses. Each course of chemotherapy is generally split up by a few days, either 1 week, 2 weeks, or 3 weeks. Generally 3 weeks for some drugs and 1 or 2 weeks depending on which other drugs are being used.
We give 3 weeks because we want the bone marrow to recover. What happens when you give chemotherapy is all cells which are fast dividing are basically hit or suppressed. This includes your bone marrow, includes the mucosa of your oral cavity, the mucosa of your internal lining of your intestines, which is why very often you can get a sore mouth, you can get diarrheas, and your blood count will drop following chemotherapy. Normal lifespan of a white blood cell is 7 to 10 days. That's why the lowest blood count which comes up is between around that time. And white blood cells prevent prevent somebody from getting infection. So when the white blood cells drop, we give certain injections to artificially make the bone marrow work harder and to decrease these chances of getting infection. All these advances have now made side effects of chemotherapeutic drugs much more manageable. But the one symptom which really troubles breast cancer patients and ladies is loss of hair. So loss of hair, loss of appetite, and nausea, vomiting are the major side effects. Unfortunately, we have not been able to really win against loss of hair. We do have something called a cooling cap, where they put something on your head and cool it so that the chemotherapeutic agents do not reach the scalp or points where the hair is growing. But these have not always been proven to be very effective and hence have not really reached widespread use. Loss of hair can't be controlled, but you can come to terms with it. There are different things we can offer. Of course, nobody likes it, but you do get wonderful wigs today, and no one can even make out that you have actually lost your hair. And some people actually tend to prefer using scarves, and they learn different ways of tying these scarves in such a beautiful manner that it really looks like wonderful headgear and people get away with it. I've had young girls in the 20s and 30s doing this and being very happy and saying, oh, we are much happier with this rather than wearing a wig. So chemotherapy is more of a mental block. There are some physical side effects, but newer technologies and drugs have allowed us to get over these. The other range of drugs are the hormonal drugs. When we say hormonal, it's not extraneous hormones, but basically anti-hormonal drugs. Certain cancer cells have markers on their cell surface. For example, for estrogen. So we give an anti-estrogenic drug which goes and blocks the estrogen. This prevents the signals being transmitted into the cells and allowing the cells to multiply and decreases the multiplication of cancer cells. Anti-hormonal drugs have probably been the most successful story in treatment of breast cancer over the years. They've been around for nearly 40 years and they are so cheap. They are given for 5 to 10 years and they do have side effects, but absolutely minuscule compared to that of chemotherapy. There are two types of anti-hormonal drugs. One range can be used in premenopausal, that means young people as well as old people, both. While the other range can only be used in the ones who have reached menopause. It's not true to say that once the ovarian function stops at menopause, that there is no estrogen being formed in the body. You have a gland called the suprarenal gland, which produces androgens, the male hormone. It circulates in the body, and when it goes to the fat or to the bone, there is an enzyme called aromatase which converts these circulating male androgens into estrogen. So even postmenopausal ladies do have some estrogen production. And if they have an estrogen receptor positive subtype of a cancer, then these cells can multiply because of this estrogenic stimulation. And these drugs which block the formation of estrogen, called aromatase inhibitors, can be used in postmenopausal therapy. The third range of drugs is called targeted therapies. These are like snipers. The anti-hormonal treatment or what we call the anti-estrogenic treatments are also targeted drugs, but they have become so cheap that we tend to use the word targeted therapy only for these very expensive drugs which are now out in the market. The commonest one that we use is called, the chemical name is trastuzumab, and the most commonly used drug for many years was Herceptin. Of course, that's a foreign drug and there are many Indian companies now manufacturing the same drug at far lesser cost. But Herceptin has been the major success story as far as targeted treatment goes. It's the poster boy. Some patients have an epitope on the cancer cell or a marker on the cancer cell called HER2. And this HER2 makes these cancer cells more aggressive than the ones which are HER2 negative. But when we give this anti-HER2 treatment, it makes these cancer cells very docile. In the sense, the outcome of the breast cancer patient is far better when they are given this anti-HER2 treatment. So these are the drugs which are basically being used. Now, there are newer advances. Does everyone require chemotherapy? No. When we get a final detailed report after surgery, we know information about the size of the tumor, the grade of the tumor, and just to recap, grade is not stage. Grade refers to how aggressive are these cells within the tumor. It depends upon the markers that we talked about. We look at certain things, certain local aggressive factors which we see in the tumor. Then we also see how many lymph nodes in the armpit are involved. And we look at a combination of the biomarker, the estrogen receptor, the progesterone receptor, the HER2 receptor, and the proliferation rate, which we call Ki67, which tells you how quickly the cells are proliferating in the body. So we put all these factors and then try and get sort of a jigsaw puzzle picture which emerges and tells you how likely is this tumor to be aggressive and likely to spread in the body, and how is this, by utilizing certain statistics, we may be able to project that 5 to 10 years down the line, how well is this patient likely to be. Depending on the likelihood of a tumor coming back, we decide on the usefulness or what is the actual treatment to be given. So it's not that every patient will get chemotherapy or everyone will get hormone therapy or everyone gets targeted therapy. It all depends. We call this individualization of treatment. For many years, we were doing this treatment based on the appearance. That means the size of the tumor, how bad or aggressive is the tumor, and some of these markers. But there are newer tests which can be done in certain groups of patients. These are called genomic tests. So instead of looking at the appearance, we are now isolating the DNA from these cells and looking at patterns of genes. So these are called genomic tests, and they look at these genomic profiles. And these genomic profiles can then tell us, are these cancer cells aggressive? Are these cancers likely to recur? And what should be the optimum benefit? They can help us decide in an individual patient, should chemotherapy be given or not? And the maximum use in these patients has actually been to avoid the use of chemotherapy. Do you have any more time? Yeah. So for this is the latest advance, which is called genomic profiling. There are, of course, all the time newer drugs being discovered, and unfortunately it always comes in the newspaper as the greatest advance in cancer of the new drugs. But it's very, very important to understand that very often these newer drugs which are proclaimed to have such lasting or utility actually have not stood the test of time. So very often over about 5 to 10 years we realize that these treatments may be useful or not. But yes, they have made a dent, and we have many, many options of treatment. More important now is, if you look at what is actually happening in our country, breast cancer rates have not increased rapidly, but the numbers have increased by the sheer weight of our population. So breast cancer has become common. We are in a city like Mumbai, we are still seeing 50% of these cancers at an advanced stage, which means that the battle is practically lost when they come to us, and the drugs are likely to be ineffective, and we will be doing much more extensive surgeries to try and salvage some good results from these patients. What we want to do is what has happened in the West. In the West, death from cancers and breast cancers in general, and specifically really, have been dropping from the 80s and 90s. We are not seeing the same thing happening in our society, which means that people are still coming to doctors at a late stage. So number one, we require to increase awareness that yes, breast cancer can happen. The commonest age for detection of breast cancer is 50 to 60, but the incidence increases from the 40s, and one should be worried about any new lump which comes up in the 40s. Lumps which have been existing from the 20s and 30s, which haven't changed at all, are not the ones that we worry about. So these are things to remember. Secondly, you can decrease the incidence of most cancers, not only breast cancer, by living a healthy life. So eat well, exercise regularly, and be judicious in your activities, and that may decrease the incidence of cancer. And finally, if someone is still very unlucky to develop cancer, it's really important to understand that about 3 or 4 weeks ago, if you read the newspapers, there was a cancer victim who climbed Mount Everest, which means that he's probably more fitter than, or he or she was fitter than most of us. There's Lance Armstrong and so many other sports people who have actually done extremely well after being treated with extensive chemotherapy. So life after cancer does not really necessarily change. And it's also important to realize that very often in early cancers, after surgery, when you get treatments, the treatments are not meant because somebody is riddled with cancer, but the idea is to prevent the disease coming back. So it's important for all of us to realize that yes, cancer is not good news, but cancer, if diagnosed early, treated effectively, can give you really a long lifespan, and you can have an extremely good quality of life following cancer. Thank you.